Hi, everyone. I'm Jen Gorman, and I'm here with Dr. Hagit Berdishevsky. I am a teacher, a practitioner, and a patient advocate for people with scoliosis and spinal fusions. And you can find me at scoliosisandbackcare.com as well as at scoliosisandbackcare.com on social media. And I'm thrilled to be here with Dr. Hagit Berdishevsky, who will speak to us today about osteoporosis and the spine. She is a physical therapist and a Schroth therapist. She's the founder of the Scoliosis and Spine Online Learning Center, and she has two clinics, one in New York, Schroth NYC, and then also one in Israel. And I'll let you tell us about the one in Israel and pronounce its name.
Sure. For me to start, or
Sure,
you?
go ahead and let us know what the name is
Okay,
first,
so
and
it's
then we'll
in
go through it.
Hebrew. Sure, in Hebrew it's called Yetziva Tova, meaning good pasture. And yes, it's since I moved to Great Israel.
Excellent. So, Hagit, why don't you introduce yourself a little bit further? I kind of did a little overview, but just maybe tell us a little bit about yourself and how you've come to this space about the importance of bone health, osteoporosis, and the spine.
Sure. So is I think I can start. Maybe do you want me to share the presentation and I
Yes,
start a
go
little bit
ahead.
with
Yeah.
that? I
And I
think we
will go ahead and share here. Oh, we just lost it actually. Can you
Yes, I'm bringing it
okay,
over.
no problem. So Hagit has this beautiful
Tell me
presentation for
you
us
see
to also
good.
look at. Yeah, there we go. Go ahead.
Okay. So first, I have to say thank you, Jen, for hosting me. It's always lovely to work together, to create together, and I think it's a great opportunity for the public to get education. And I thank you for that. And you are a great person with all your background, which one day I should interview you. Yes, to know about you. Um, so I will say first shalom, as we say here from Israel. These are live pictures. I just took them before I came here. I took 2 hours with my daughter on the beach, and I came to you guys. So you're welcome to Israel anytime. The borders are open. For me, as a physical therapist who graduated Hunter College and then Florida, my doctorate degree for spinal conditions with some emphasis on scoliosis. I joined the Hospital for Special Surgery in Manhattan, New York, rated as number one in the United States. I had no clue when I luckily was accepted to work there. And I work closely with the man here, the man, really. His name is Dr. Buachi. He is a spinal surgeon, almost like a pianist or a great performer. No, he's doing a great job, great work on patients with scoliosis and spinal deformities of all ages. And I was lucky to join few missions with him in Ghana, Africa. I went there 3 or 4 times, and while the surgeons treating and operating on all of these kids who actually have scoliosis or kyphoscoliosis or hyperkyphosis, which is also related to what our topic is going to be. We did the physical therapy for them on a mission of 2 weeks. And that brought me very closely to have an interest on the spine. And the spine is fascinating, honestly, because there is so much of unknown and so much to research and discover and treat and help people, and as much as you can, as much as possible, conservatively and medically and surgically. So while I was working at HSS, actually, I was given the opportunity to run an osteoporosis wellness class for about 5, 6 years. And then I saw twice a week for the public patient who came from Manhattan to do exercises for osteoporosis. And before that, we give a talk, we explain to the population what is osteoporosis and what type of exercises are desired to be, what to maybe reduce or try to avoid or eliminate or modify, so you can live with a healthy bone and safely and prevent the progression of even of osteoporosis and what it is entail. So a moment before we start on that topic, I always want to say really thank you for all my teacher and all my inspiration, from the Schrott, Krista Schrott, to all the surgeons I work with and the teachers that taught me what I know. And of course, really whoever all the research team all over the world that we get the information from and just delivering it to others. And the experience, of course. This is a little bit about myself, but I think this you can look later because this is going to be recorded. And what I do is mainly as a physical therapist, teaching postural and teaching exercises for people with all spinal condition primarily. And of course, I treat other, as a physical therapist, I can treat any other body part, but my interest is about the spine. One second. And I use the Schrott method with the modification as needed. Some of my publication, thank you to all the people who helped me with them, which you'll be able to see as well.
Great. So let me ask, so getting kind of into the osteoporosis, let's talk about what osteoporosis is and how it does affect the spine. You have so much experience with the spine. So that's what I'm really curious about, is like, how would you define osteoporosis and how does it generally affect the spine? And then maybe we can get into some of the risk factors as well.
Sure. So osteoporosis is a systemic skeletal disorder with compromised bone strength that predisposes an individual to increased fracture risks. This is the definition of the International Osteoporosis Society. And it says here in letters at the end, at the bottom, it's a silent disease. It's a silent disease. What does it mean? Many people ask me. Osteoporosis primarily affect the bones. And the bones do not have nerve stimuli. So typically when you fracture a bone, especially in the spine, you don't feel it. Or if you have hairline fracture, or if you compresses the bone, which we're going to get into it, how it's related, and therefore you don't know about it. So people can walk on the street and may have osteoporosis and may have even the risk, or they have fracture something or in the spine, and they don't know about it. And that is why it is so important to discover, to do analysis, to take tests and exams as we reach menopause, women or men also of the same age, to start to test if we have osteopenia, which is even one level before it, we're going to get into it, or osteoporosis, because the risk factors, as you asked, are very detrimental and important. And for that, we're going to go to this. So, as according to the US Department of Health and Human Resource, Coronary heart disease affect 12.6 million. This is about a good 5 or 6 years ago. I did not put the up to date. Heart attack affect 1.1 million. Obesity, 50 million. And osteoporosis is a very, it's an important systemic problem or condition that affect close to 45 million in the United States, and that was about 5 to 6 years ago, and it's very important, more than even heart attack. So when we look at the differences between normal bone and osteopenic is a level before osteoporotic. I will talk about it soon. But osteopenic or osteoporotic bone, we see the difference in the density of the bone. The bones they do, especially the spine. This is a pictures of the spine. This type of bone have some pores. It have some, you can see holes inside it. But the structure is so strong when it's a normal bone. It's thick, and there is a low fracture risk. It's a mesh. It's a beautiful mesh. But there is really decrease in peak bone mass when a person suffer from osteopenia or osteoporotic, and that is a disturbance to the architecture of the bone and increase the risk of fracture. You can see this bone here.
Yeah, that's a lot.
Yeah.
You can just see that it's almost like the architecture of the bone is different.
Correct. And it is prone to fractures. So what is really, we're talking about peak bone mass, and that the bone mass, the density of the bone decreases when you become osteoporotic. But let's talk a little bit about it. So what is it? What is peak bone mass? It's the amount of bony tissue present at the end of bone maturation. When is the end of bone maturation? If we look here, men is about age, and men and women is about age 30. That is when we get our maximum bone mass, and we need to keep it. And how to keep it? Keep it with the right nutrition, keep it with right exercises, with weight-bearing exercises, keep it with, if you need medication, if it gets low, but it's very important because from age 30, there is a decline. And you can see number 2 is menopausal bone loss, and number 3 is bone loss with age. So both men and women suffer from that. And when we measure the bone, we measure basically in grams how much of calcium is in centimeter of bone. So you really measure with radiation, you measure via the DEXA, you'll see it in a moment, via this machine. It's an X-ray absorptiometry machine that can measure precisely the amount of calcium within centimeter square. And the measurement goes in the spine and in the hip. This is how it's usually being measured. And the determination of peak bone mass is basically, it's hereditary. About 60 to 80% is what we get in the genes. Physical activity influences the bone mass. Nutrition, as I said, calcium intake, vitamin D as well. Hormonal status, we'll talk about it later when we get to scoliosis. It's interesting, but some hormonal status affects low or high bone mass, and also in terms of ethnicity. So the World Health Organization definition of osteoporosis, bone density, based on something that when people go and lie down in this machine and get the radiation, which is not really radiation, it's just it's a special rays that going into the spine or into the hips. Then the doctors measure it by something called T-score. It's the number of standard deviation from the mean 25-year-old woman. So what does it mean? Normal, when they print the result, you see a T-score which is better than -1. This is how it is. Okay, you can inquire more details, but this is how it is. Normal bone density is basically 0. And what does it mean? For women, 2.9 gram per centimeter square, and for men, 3.8 gram centimeter square. So yes, men's bones are more dense, more stronger, and more heavier. When we go below -1, we're starting with osteopenia, low bone mass. When we go to the red zone, below 2.5, this is a presence of osteoporosis. And you don't need to wait for the red zone. You should start to do something when you become an osteopenic. So what are the risk factors? The risk factor to have osteoporosis primarily is the fractures. Because, as I said, we don't feel it otherwise. What we feel is when there is fracture, when there are falls, and falls also related to decreased balance. Decreased balance also related to our aging or fragility or lack of exercises. It's all going to come into play very soon. But these are the most riskiest factor when you have osteoporosis. Number one for fracture is the vertebral body, the front of the spine, not the back where we feel usually these processes, but on the spine, it's the front of the spine, as you can see here. And when the front of the spine is fractured, that will give into a posture that I will show you soon. The second most common is the hip joint. And the third common fracture from osteoporosis is wrist. And typically the wrist is because falling. And you fall on a stretched hand and then you fracture the wrist. Women are at higher risk of fracture, about 2 to 3 times their men. It could be possibly because the bones are less in density. It could be because maybe women doing more than men in terms of activities or risk, I don't know. But I think it's more related to the fragility of the bone. So regarding spinal compression fractures, it's not that I want to create any catastrophe here or to scare anyone, but the topic is very important as we age. And the reason is because as a physical therapist, and you, Jen, also someone who is in this world of teaching, unfortunately, I see many people doing the wrong exercises when they have osteoporosis. So it's coming from a place that I want to present the importance of what can happen when you have osteoporosis and you're doing also wrong movement exercises or not treating yourself even. I also I'm accounting people who don't think that they need to treat themselves medically, but it's so important. So there are going to be 1 or 2 slides that show the importance of it, and then we're all going to talk about what to do about it. So really, spinal compression fractures are the first to show the sign of osteoporosis. You can see the bone. You can see the bone with osteoporosis. About 700,000 fractures per year due to osteoporosis. The majority is due to this hairline or wedging fracture that happens. It can happen, unfortunately, if you sneeze and you have osteoporosis. And of course, if you bend over or lift things. So that tells us that we need to know if we have osteopenia or osteoporosis. to find out, not to be ignorant about it, okay? Mainly it is in the thoracic spine, not so much in the lumbar, because in the thoracic spine, we have the natural kyphosis of the back, which is already in some forward flexion. That is the position of, you see the spine here. And if it occurs more during flexions.
And Hagit, when you say it occurs more during flexion and there's already some kyphosis, that's when the back body is moving further back and we're kind of rounding forward. Is that correct?
That's correct. We're going to get into it in a second, but I'll show you
perfect.
for now.
Great. Okay.
Here, right. Here is basically a cascade. This cascade is a good picture for osteoporosis, somebody who is slowly maybe developing osteoporosis, and due to that, some wedging and some compression, like that. But this also can present just something that happens to us during aging. And if we don't make an effort to keep our posture upright and do the correct exercise, it's not necessarily we're going down the right, from left to right, but it's a risk. So we need always to keep our posture upright. And exercise for a person who is slowly becoming more kyphotic or round back or osteoporotic, these flexion or more bending exercises will not be the right, but we will talk about it very, 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 very soon. So I just want to say also that there is increase of risk of further fractures if you don't pay attention to your osteoporosis and treat it. Because only 20% are symptomatic, meaning 80% of the population with osteoporotic don't even know that they have it. So I encourage testing. So here you can see, let's say a straight spine with some, I can show you here, some compression from decrease of bone density. So whatever we have above the head and the rest of the trunk is compressing. And from here, it can go to the right side with more compression. You can see all the arrows describe, and more kyphosis, or what we call hyperkyphosis, which soon gonna come together. And we need to be aware of it. So osteoporosis have a correlation with hyperkyphosis. And from here, we're going to go into this description. Because when we have decrease in bone density and mass, when we started to have some compromised posture also in addition or without, but anyway, this decrease in bone mass from the center, from the front of the bone, then the wedging, look at the vertebra itself in comparison with the vertebra before, it can lead, not necessarily, unless you're doing something about it, to hyperkyphosis. So this is a nice table, maybe everyone can refer to it later, about symptoms and sign and functional and health-related quality of life and future risk about osteoporosis. And here it's where it comes from. So the symptoms sometimes, just to pay attention, maybe there is a little back pain, maybe there is some disturbed sleep. It's all different symptoms that people can experience. And, this can go also with herniated disc. This can also go with many other factors, but any other conditions. But it is here to pay attention. Anxiety, some level of depression, maybe self-esteem when you started to see the way your body go to. But the signs for me are more important. I want everyone in the audience to pay attention. If you lost height, specifically about 2 centimeters, which is close to 1 inch, over 1 to 3 years, So if you can look back and say, hey, 2 years ago, 3 years ago, I was higher by 1 inch, I think you should test. And if you say to yourself, I lost 6 centimeters, which is about 2 inches, historically, from I knew when I was 20, I was 5'7", and now I'm 5'5". You lose 2 inches, you should check yourself. Hyperkyphosis. If you see that your trunk become more rounded and you notice your posture, it is something to also go and test. As well as these signs, some decrease in lumbar lordosis, meaning more straight low back. If the abdomen is protruding forward because of more collapsed trunk, if there is some reduce in breathing, and if there is a weight loss. All of that to pay attention and to test. And there is really very nice 2 tests that one can do for themselves. Ask their partners or ask a local physical therapist or fitness instructor. Is these 2 tests simple to measure and to the possibility? One is rib to pelvis distance. You can see this, the physical therapist put fingers between the last rib number 12, to the pelvis rim, and you're supposed to have about more than 2 fingers. If you have 2 fingers or 1 finger, you are at risk for osteoporosis and collapse. And then you're looking at the wall to occiput. Occiput is the back of the head. The wall to head distance, and the inability to touch the wall with the back of the head is a positive sign also to start to check what's going on in the back, in the spine.
And Hagit, and you may be getting to this, but this is kind of an interesting question that someone is asking about one of the signs of osteoporosis. So
Yes.
The question is, it's kind of a chicken or the egg question. Is it that hyperkyphosis causes osteoporosis, or is it that osteoporosis causes hyperkyphosis, or could it be both? And
wonderful question.
Yeah.
Wonderful question. So let's describe osteoporosis, hyperkyphosis, and its relationship with osteoporosis.
Great.
And I think it's a very good time. So a little bit, just a moment, as you know me already, in order to describe something, we have to go a little bit back. So back to when? Back to the time that if you believe in Darwin, if you believe that we are coming from the chimpanzee, but even if not, but I guess in this example you need to, the chimpanzee or the mammals, they were all going on all 4. And their spine was basically one round back, with the pelvis and the trunk in one round back. When this chimpanzee wanted to get on their feet and reach something from the tree to stand up, they came to stand like that, still with a round trunk. Center of mass is here. They wanted to reach a little bit higher, so they had to push their lumbar lordosis very much forward in order to stand up. But this is not a good standing up position. There are many other things they couldn't do. And then the human being came from God or from Darwin, whatever you believe. And the human being design is a very special design with, as you can see from the side, normal curvatures of the back. So we could stand and walk upright. What are these normal curvatures? These curvatures from the side are, and these are the names, and I'm coming into it because it's important to understand what is kyphosis. So let's start with the kyphosis. The green area is the thoracic kyphosis. That's the name it was given. I guess it's Latin, kyphosis. It's a round, it's a curved like that. Then the cervical and the lumbar and pelvis are in lordosis. Lordosis is basically a cave, like a cave, but it's at the opposite direction of the thoracic. Now, we have different postures. And we're going to consider now this posture here as a well-balanced posture, where this plumb line, the red line, is bisecting the lobe of the ear, the shoulder, the hip, and the ankle joint. And then there are different type of postures. This one, in the yellow one, is more of a hyperkyphosis, increased roundness of the thoracic spine in this case. And if you look on the side, you can see that normally the degrees of thoracic kyphosis normally is about 26 to 46 degrees. It's a wide range with some standard deviation. And then hyperkyphosis, consider in different literature, you can find some different numbers. Don't take me on this number, but this number is coming from one of the SRS, Scoliosis Society, Daniel Chopin literature, and more than 55, meaning hyperkyphosis. We're gonna get into it very soon. 1 second. So hyperkyphosis is in reality now roundness of the back, more than the average. And with that, of course, comes some risks. A little note too, hyperkyphosis can be something that an adolescent grew up with, and then it's called Scheuermann kyphosis, which is a condition that a teenager or juvenile can have. It's a condition. Or hyperkyphosis can come the whole trunk or just part of it from aging. And when we look clinically, you can see, I think, you can see the difference in the kyphosis, but I'm going to go a little bit faster because I want to go into the question. With hyperkyphosis, basically the spine is migrating, the spine is pulling back from the sternum. The sternum is the breastbone. So the spine is starting to go backwards because of the wedging that is happening in the vertebrae.
And Hagit,
so this wedging, yes.
When you say wedging in the vertebrae, that means the front of the vertebral bodies are becoming shorter.
Right, like that.
Okay, great.
Correct.
Thank you.
Very good. So even normally, if you look at here, normally, you don't see much, but even normally we have less height in the front than in the back. But when it's hyperkyphosis, this narrowness of the front is much more pronounced. Basically, it's you can see it's much more severe, I can use the word, than when it's not. Look at the vertebra below right here, still narrow in the front and in the back, but just above it, you can see vertebrae that are very narrow in the front. So if you have that, you have hyperkyphosis from aging, not from disease. Hyperkyphosis from aging, for example. And you also have osteoporosis, you are in increased risk of all the consequences that come with osteoporosis and hyperkyphosis, which is related to decreased balance and risk of fractures and the decreased strength, compromise on your, a little bit on internal organs. But if you have Scheuermann kyphosis, let's say, if you have this kyphosis coming from young age, I didn't see a correlation between kyphosis, like hyperkyphosis from young age, and osteoporosis. There is more correlation of osteoporosis and adulthood hyperkyphosis, because the osteoporosis that create the vertebral fractured, as I showed you here, can fail the trunk from left to right, fail the trunk, and then there is a collapse. And that collapse is the hyperkyphosis that we see, that came from the osteoporosis. So if it goes vice versa, is hyperkyphosis someone that have hyperkyphosis from aging, from decreased muscle strength, just cannot hold themselves upright, not necessarily having, let's say, a disease, a condition. This I'm not sure. That hyperkyphosis bringing osteoporosis, the correlation is not strong. But osteoporosis and fractures and risk of fracture and fractures creating or bringing hyperkyphosis, that direction it is going. Yes, this is the direction, and that is where we need to take care of. So what can people, if you have any question before I move into what can be done about it, I'll be happy to.
No, let's talk about the prevention, and then I do have a specific prevention question.
Sure. So to prevent osteoporosis, and the prevention is something at young age we need to incorporate or educate our children. I remember this statement when I was working at HSS and lecturing to whom? Lecturing to the adults and the elders, because that's when they come to treat it. But we need to start with our children's, because it's something that can develop due to, we saw, lack, decreased calcium, nutrition, strengthening, exercises. So we need to install that within our children. Have a healthy and varied diet with plenty of fresh fruits and vegetables and whole grains. Today, my daughter just asked me, why do we need to eat so much vegetables and fruit? Why can we eat all the things that we don't like to eat? These are the tastiest things. And this is an answer for that. And maybe you can talk to your children and not to show them things that will scare them, but yes, to talk about people in your community that you see that maybe if they did all over their life, they could have prevented. But it's also always a question. You never know, things you cannot say, if you do that, you will never get osteoporosis, because it's also genetic and hereditary. Eat calcium-rich foods, absorb enough vitamin D. So we do need to be in a safe time in the sun. Avoid smoking, limit alcohol consumption, and do regular weight bearing and strength training activities. And mainly, really, is all of that to empower yourself, because you can do the exercises and the medical and the nutritional prevention by yourself. And that's what we should all teach our friends, people, community. The exercises that strengthen the back musculature, in red, back, because the osteoporosis is basically leading into the hyperkyphosis, the round back. From there come the risk of fracture and the continuation of the poor posture and collapse and decrease of balance, because once the trunk is leaning forward, you are losing your sense of balance. The feet cannot keep up with the posture that falling forward. There is a lot to say about the balance and walk, but it's all about the back musculature and I will talk about it soon, a comparison, great comparison study between front strengthening and back strengthening. Patient needs to open up the front of the body. And the 6 points program that we developed at HSS back in the days target all of these that you see here: posture, strength, flexibility, balance, weight bearing, and body mechanics and patient education. A great course to take, this is more for instructors, but I will talk about it right here, is by Sarah Mix. Sarah Mix is a woman, a guru in osteoporosis from United States. And one of the things that I liked before I come into the exercises front versus back, she said, and I put it here first, if you only have 5 minutes a day to do something about osteoporosis, is lie down on your back and decompress the spine. It is great because with decompression of the spine, you are alleviating the hyperkyphosis, the roundness of the back, the pressure on the spine, the pressure on the hips, and you are opening the front. And you can, yes, Jen?
I just love that. It's one of the things that I teach a lot, is lying on the back, and I put the shins on a chair. So
good,
just to like decompress. I say it's the closest thing that we can get to being in outer space where there's no gravity.
Oh, fantastic. I should
That's as
edit
close
here,
as we
out
can
of
get.
space. Right, I will edit for the next time. Perfect. And you can see here the woman is raising her palms up in order to open the chest as well. Her face is parallel to the ceiling. This is very important because if you don't get your face parallel to the ceiling, you are going to round your back and neck, upper thoracic. So even if you need to put a towel or something, so your face is parallel to the ceiling. Now, regarding what type of activity, because probably this is what people here in the audience wants to know, what can we do about it? Aside of medication, aside of the nutrition, what exercises are recommended? So this is a gold standard study that was posted in the Osteoporosis International, a study that probably will not be done again because there are part of it that is at risk now when we cannot allow people to do some of the exercises that was done in this study. So what is this study about? They took a group of women, age 50 and above, a large group of people, of women, and they divided them into extension, backwards bending exercises, flexion, abdominal work, sit-ups type of exercises, a group that combined got a little bit of this and a little bit of that, and a group that got no exercises. And they wanted to see, among other things, strengthening, but the most important that osteoporosis, the hallmark is the vertebral fracture, to see what was the rate of new fractures due to this regimen of study. Now you can see why we cannot do this type again research. So the group that got the most new vertebral fracture, 89% of the people in that group was the flexion bias exercises. Second was the no exercises group. So this is really what's interesting. No exercises got the second place for developing new fractures. Then the combined flexion and extension. And in the lowest rate of new hairline fracture was the extension group. It was significantly different. And the extension group, we don't know what else on a daily basis they did and what was the severity, but this was a significantly lower.
That's a lot lower.
And right. And very interesting is not doing anything.
Yes.
So it's important to do something about it and join your class, my class, whatever we do. And this is a handout. Whoever wants, I can send it to you, Jen. If people reach you, you can take it. This is one handout of, I think, 9 exercises that recommended for people with osteoporosis and hyperkyphosis. And all of them here are to open the front of the spine and strengthen the back of the spine. Nothing in bending forward.
And what's
I do,
interesting
yes.
in these exercises is that they're working the back extensors, a lot of them, but
Correct.
not all of them are actually taking people into spinal extension. Is that correct? Am I seeing them correctly?
Beautiful. Beautiful, Jen. So, right. Here I see, and actually something that I also teach more than it's a whole topic by itself, but you will see soon with the exercises. Hyperextension, extending the trunk, like overextending, is it's good for mobility, for opening the front, flexibility of the round shoulder and chest. It's great for mobility. But you really want, at the end of the day, you want to assume exercises that are kind of functional and more in neutral, bringing the hyperkyphotic, the round spine, into a neutral spine and stabilize it there. Because this is the reality on an everyday basis. People should be able to be in upright, neutral, good posture rather than overextending. But I will have few exercise like that. And the result was that the progression of kyphosis was greater in women who did not perform the extension exercises, and significant difference between the group. Oppa, 1 second, something happened here. Are you still with me, Jen?
Yes.
Okay. But let's continue forward. We are encouraging basically expansion from side to side of the trunk. As I said, less with over. So I want to show here, with your permission, a very fast few suggestions for exercises. This will be available for you later, but I think it's good that you will see. So, for example, sorry, here, sitting, oppa, something happened. Not this one. That was last time. And this, why is it happening to us?
I'm not sure.
Okay, maybe I'm pressing. Not this. Where are we? Here. Play. Aha, it doesn't allow us to play.
Oh,
okay, I'll try to do it here. That is great.
Do you want to show
Maybe
us?
Okay, I will do it in 1 second. Sorry, guys. We'll be right with you. Let's see if that's work for us. I guess on this stream.
Yeah, it doesn't seem to want to play.
Right.
Would you like to show us live? I can make you bigger.
Okay, wow. Let me just close it. I will in a second. Do you see what I see? I do now?
We're still seeing the PowerPoint.
Just the PowerPoint?
Just the PowerPoint, yeah. If you want to share a different screen, then you could try to.
Yes, I'll try to stop. I'll share here.
And then go to the other.
Share. Screen share. Window right here. Okay. We together?
And we see that. So if you open one of those.
Right.
And I'm guessing, Hagit, you have quite a vast library of videos available on your website. Is that correct?
That is yes and no. No. Okay, do you see now?
Yes.
Okay. So sitting, yes, tell me.
It's not playing.
It's not playing because for me it's playing.
Yeah, it's not playing for us. But it's not playing for us for some reason. I don't know why that is. I'm wondering if maybe the best option, if you feel comfortable, is showing us.
Sure.
Okay.
Wow. Okay.
So I will solo lay you out.
So yeah, because I want to talk. It's important for the talk. Yeah, we can see.
Yep. Mm-hmm.
Okay. So what we are looking for is to open the front of the trunk, basically, avoid roundness, avoid any exercise that is flexing the spine, because you already saw what it entails in terms of the fracture. Okay, so you can sit down, take any elastic belt, lifting the elastic belt, unshrug the shoulder always, opening, I just need to move it this way, opening the arms. By doing that, you're working the back musculature. You can go diagonal and inhale, bring the arms down. Diagonal to the opposite way. All the back extensors are opening and bring it back. And again, open side to side. For example, you can do yes.
Hagit, with that exercise, do you recommend that in a seated position, standing position, lying on the back? Or
fantastic. You're always good. You're always good. These exercises, right, I show you in sitting, but it can be done definitely in standing. It can be done with squat. So you get some legs, weight bearing, abdominal work, but always with the back in basically in neutral spine, or in relative to flexion, it's an extension. As we said, balance is also decreased with people with osteoporosis. So if you can, I drag my feet and I lift my leg up. So you can go ahead and do few to either side and always incorporate with balance. Since osteoporosis need weight bearing, you're allowed, you can use weights, but when you use the weights, Don't let the weight pull you down. Maintain. So you can do even, again, balance. A little lunge, not a lot. You can lift some weight. When you open, anything you do in terms of opening, I really encourage the elbows away, the armpit away, the ribs away, and not, as you asked me before, not so much extension, because that aggravates actually the back. It's too much muscle activation. We need to keep the elbows, shoulder, a little bit in front even, and work to expand the side. You can also just stand and hold and pull side to side. It can be a dowel that you hold. Standing with a dowel and expanding. You can, when you get advanced, balance is very important. So you can lift and open and go for a star, maintaining yourself open. You can, I really like exercises that are also on the ground. You can go about, 1 second, depends what equipment you have. But for example, if you have any kind of box or without, and you lie on the box, you lift.
Looks like we're having a little bit of
You
trouble.
can use your legs. You can use your story to pump, to have some action. You can swim with the legs. You can, if you advance, you can swim with your arms. Anything. When your extremities are off the ground, your back muscles work. But you need to know how to work it. That's why it's better to work with a specialist, because I don't want you to hyperextend. You can go about a roller.
So Hagit, with the box,
roller, everyone can get on Amazon, such a great tool. And lie down on the roller under your armpit. Yes.
Oops, and we just lost her. So I will come back in here. Hi, everyone. It looks like we lost Hagit's connection there. So hopefully she will come back and join us. There she is. I'm going to add her. We lost you for a moment. But with the roller, you were doing an opening through here. Is that correct?
Correct.
Great. And then I wanted to ask you about the box. So even when you were using the box, because I think the hard part of using the box is you were still staying more neutral. Is that correct? And stabilizing the spine there. And it was just the work of keeping the limbs, against gravity. Is that true?
In this example right now, yes. But
Okay.
I'm not against. I am not against. I'm the opposite. I do it a lot with my clients. Lying. Maybe I'll take this. I think I know what you are referring to. So I do where holding the belly, straightening the legs, okay, coming up, okay, but and you need to know what to do and how to do about it, or just lifting the thoracic, or lifting even higher, or using your arms to open. It can be like that, or you can keep the trunk in neutral.
Right.
Because in order to lift, when I lift up, I use my extremities. But if I am not able to lift the trunk up, or most of the population, especially if they are a little bit rounded to begin with. So bringing the spine into neutral and working on moving the extremities off the ground so the back muscle works.
I see.
Yeah.
Great.
And a lot of things. You can even just lie down. You lie down on the roller if you have a roller. You spread your fingers. Touch with all your fingers while you're doing, core work, which is also important. Then touch just one finger, the middle finger on the ground. Lift one arm. Switch, lift the other arm. Many workout with the legs to work the abdomen, the core, while you're opening here. You can take elastic belt and open with the elastic belt this way.
Yeah. Great.
Yeah.
Lots of ideas.
There's a lot of exercises, and they are all of them in, as you can see, we call it extension exercises, okay? Even with the roller, and opening, maintaining, or working with your shoulders up and down,
right?
Maintaining. Everything can be downgraded, progressed, or regressed, so to help everybody.
So it seems as though like the themes are working the back extensors, opening the front of the body, working on balance, and then also strengthening the legs. Great. Excellent.
Correct.
Ah.
Okay, good that we did it like that.
Yeah. So I wanted to ask a little bit about bracing for osteoporosis. Is that a good place to go from here?
Let me just find the presentation. I'm going to close it here.
Did we miss anything in the fitness and physical therapy arena?
No, I think it's very good. We're coming into bracing. That's actually a good point.
Because I'm curious about bracing adults in general.
Sure. So this is a great brace. This is called the Spinal Med, very popular in the United States, accepted or received by Medicare for just a prescription. It's a great brace for adults. It have this metal inside here. You don't really see it. It's an active brace. Great study about it. Strengthening, and this is a very good point actually, Jen, because many doctors, not just in hyperkyphosis and osteoporosis, I encounter it every day of my work. Doctors afraid that bracing will weaken the spine, that bracing will prevent strengthening because you're going to be dependent on the brace, and it's wrong. There is no one study out there that show that bracing will weaken the spine or the muscles or whatever, and just the opposite.
And
so, yeah.
With bracing for hyperkyphosis, because I imagine there's some people who are watching who also have scoliosis. What would you say about bracing for someone who has scoliosis and hyperkyphosis?
Tricky.
Yeah.
It's more difficult.
Okay.
So this brace the spine have to be right to left symmetrical. Okay. It's not going to be helpful with scoliosis and hyperkyphosis. For scoliosis, adults, there are a bracing for adults that are custom made for adults who feel like they're collapsing during the night, that they need more support, that few hours a day they want to wear the brace. Like this one, it's only a few hours a day. There are handmade bracing. That's what I would choose.
And those braces that are handmade, they would also take into account, they would be for the scoliosis, but I would imagine if they're custom made, they're also taking into consideration hyperkyphosis.
Yes, that
Great.
is correct.
Okay. Excellent.
That is correct.
So interesting. And
Right.
shall we talk a little bit about spinal stenosis and osteoporosis? And
sure.
What is spinal stenosis and what is its relationship with osteoporosis?
Sure. So spinal stenosis, as we can see here in the picture, what is this picture? This is a woman or a man facing to the right side. This is the spine and the cord, the spinal cord inside, and little nerves, little green, interesting, they did it in the like green, vitality, little green nerves coming out to innervate the body parts. In the lumbar, probably innervate the legs, the lower, whatever it is. What we see here is that there is a narrowing of the spinal canal or the spaces within the spine, which eventually results in pressure on the spinal cord or the nerve root, as we can see here. Symptoms of spinal stenosis vary widely from person to person and range from no symptoms to pain in the back or along the pelvis or the sacroiliac area, or radiating down to the legs or neck, depends where is the stenosis, sometimes tingling, weakness, and things like that. So basically, stenosis is narrowing of the space within the spine.
And does
Here,
that narrowing happen because of the change in the bone?
Good question. So the narrowing could be different causes, but I think the one you said is primarily there are some changes in the bone. What are these changes due to and why? Unfortunately, most of the spinal stenosis occur from age 30 and on. I can tell you, when I was 30 and I had a severe back pain starting school, I went to HSS actually, and they did an MRI, and I was diagnosed with spinal stenosis when I was 30 or 30 something, starting PT school. And I didn't know PT, I didn't know what I know now. I was wow. But I now understand, and that's how I bring it to my patient. It's an aging process. So some get it, some don't. Some is genetic, some this. Some you can't influence it, some you can. It's basically loss of height, sometime of the disc space. So more the bones get closer to each other, or some bone spurs are occurring, developing in order to stabilize the spine that becomes a little bit unsteady from herniated disc or from degeneration, from aging, from a lot of things, from surgery. So there is some extra bone forming here. And this is actually interesting because on one hand, osteoporosis is decrease in bone density.
Right.
Spinal stenosis is actually a formation of bone spurs, like extra bones are developing. But it can be extra bone in places that we don't really want to, like into the spinal canal or pressing in the joint here. the spine itself, the bone itself can be still becoming osteoporotic. And because of the osteoporosis and lack of stability of the spine and the hyperkyphosis, now the spine wants to protect itself. So it's developing some bone spurs. These bone spurs they didn't mean to compress the cord. They are developing it's like a construction to strengthen the spine. By mistake, they can press on the nerve, but it's basically to stabilize the spine from changes that happens to us.
And is there movement? Is there a difference in what we've discussed about opening the front body, strengthening the back body? Is there different types of movements that are beneficial when stenosis comes into play?
All right, you are good, as I said before. In a moment, I just want to describe about that more, and then I'll talk to you about it. Like most conditions, the spinal stenosis does not have just one cause. Indeed, many things can potentially cause this disorder, like osteoarthritis with inflammation of the bone, injury or trauma. I think I said it. And you can see here compared to a little bit narrowing. Okay. It can be done in the lumbar or in the thoracic or in the neck. Mainly the stenosis is happening in an areas that is more mobile, like the lumbar with less rib support, or the cervical, the neck. Now, hold on. If someone with kyphosis, if this become bad enough, it can narrow the spinal canal and causing also stenosis in the thoracic region. However, spinal stenosis can also give a false negative DAXA results in the osteoporosis examination. Why? Because the spine in spinal stenosis is more compressed, collapsed.
Yes.
So you see there is less disc here. The red area is without discs, like very little disc, narrowing. The spine is more compressed. And then per centimeter square, you theoretically have more calcium, but it's false. It's only on this examination because of the collapse, because we're condensing it. But generally, the body itself can go through an osteoporosis condition. Now, for your great question, Jen, stenosis, narrowing of the facets, love, meaning the body that have spinal stenosis wants to have more flexion bias exercises. Because when we bend forward, if you look at here, actually I'm going to bring this. Can people see me or not? Yes,
yeah,
not
they
really.
can. I'm going to actually make you a little bit bigger. So give me 1 second here.
Sure.
And then I will make you bigger.
Sure.
Okay, go ahead.
Okay. So this is a normal segment 2 vertebrae disc and the spinal cord and the nerve that coming out. With spinal stenosis, typically there is a narrowing of the space. So this narrowing also will compress on the nerves that exiting out. For theoretically, which used to be more people gave these exercises, they will ask patient to bend forward. Can you see me, Jen?
Yes.
To
so coming into forward flexion,
because that will open the space and give breath and room for the nerves to go. But the problem is that if elder adult with spinal stenosis, maybe osteoporosis, maybe already a little round, with stenosis, will force themselves, will do flexion exercises because temporary, it opened the facet, it opened the joint and give a breath here. These exercises have no meaning for the future. They are going to collapse. They will make you more and more round. You are going to be dependent on, I need to sit, I need to round my back, I need to stretch my back. But all you're doing is stretching and more facilitating this hyperkyphosis, osteoporosis position.
And gravity is helping you out.
Right, and this, and then lack of balance and poor gait.
Yeah.
And this does not strengthen anything. Bending forward exercises does not strengthen the trunk, does not lift you up, that does not relieve the osteoporosis. There is really no long-term meaning in all the education from where I'm coming from. So if and this needs to be discovered early and from young age. This is what I try to preach here everywhere. Elongation, expansion, upright, less rounding of the back.
Rounding forward. Yeah.
Right.
So even, I think that's an important point even for stenosis. So Hagit, we haven't talked about scoliosis yet. Is that something you want to dive into now, or do you want to save scoliosis and osteoporosis for another time?
I feel we can touch it. Maybe just 10 slides, but up to you.
Okay, let's do it then. I'm going to add back the presentation, and then we can go into some information about scoliosis and osteoporosis.
It's very quick.
Because that's something that I'm interested very much in, that relationship as well. It seems like I hear a lot of stories about people who have increases in their curvature around the time of menopause. And I just want to hear about all that osteoporosis, menopause, scoliosis, what's happening.
Yeah. Here you go. You mentioned it. You said it just correct. So for the general, just to say, scoliosis is an instability disorder with collapses and contractures. Here you can see an adult scoliosis. Adult scoliosis can be in the thoracic region, in the lumbar region, in the thoracolumbar region. It can be coming, this is a whole different topic. We can talk about adult scoliosis totally in another time.
Right.
But it can be from, they had it when they were teenager, carrying it through their life, or they develop it later in life. And this is what it's going to be about. But I also want to say that scoliosis is, of course, can start as early onset or in adolescent as well. And that also related something with the bone density. In general, it's a 3D deformity of the spine in otherwise healthy individuals. So what did the literature find? The literature find that there is actually a correlation between scoliosis in teenagers, scoliosis in juvenile, and osteopenia or osteoporosis, or what we say low bone density. There are many studies, and many studies that confirm again and again and again that vitamin D level lower in adolescent idiopathic scoliosis group. This is adolescent with no sex
Oh, we just lost your sound, Hagit. So let's see if it will come back. Oh, your mic isn't connected. So maybe the earbuds ran out. So the mic doesn't know. Let's see if this works. If not, you might just need to rejoin. Nope, we're not hearing you. Okay, I'm going to remove you and then you can come back in if that works for you. Great. So good. And then Hagit will come back in and talk a little bit more about scoliosis and osteoporosis, because that is also an important topic. And we'll just wait here for a moment with her. And I know that we have some questions in the chat that we haven't quite gotten to. And I'll try to get to some of those as well. We have lots of information that we've been going through. So let me just see how we're doing here. There she is. We'll add her back in. There we go. And let's see, Hagit, if we can hear you.
Okay, can you hear me?
Excellent. Yep, absolutely.
Okay, so studies shows that there is a correlation between adolescent, juvenile idiopathic scoliosis and low level of vitamin D, calcium, and osteopenia. And even more than that, progressive scoliosis nowadays is proven to be correlated to these levels. So children, adolescent, that their scoliosis is a progressive scoliosis, more than 25, 30 degree and on, shown to have low level of vitamin D and calcium, and are being given by our doctors, and every doctor visit supplements for it. This is
That's
in
amazing,
children.
because that's a big change, I think. About how many years has that been going on?
Wow, it's very interesting. When I visited in 2012, like a decade ago, Germany, Katharina Schroth Clinic, they were giving battles of vitamin D and calcium for every patient. I remember Dr. Weiss, Hans Weiss, the son of Krista Schroth, having shelf with this with these supplements. In coming in more into research, it's also almost in the last decade, maybe 5 years, maybe 5, and at Columbia University Medical Center, it's with every doctor visit nowadays.
That's great.
Right. So yes, even other studies and nearly all investigation demonstrated that low bone mineral density was a generalized phenomenon and a systemic disorder in patients with adolescent idiopathic scoliosis, and always associated with lower bone strength. Now, we see the girls joining the ballet or gymnastic, the ectomorph type of girls with idiopathic scoliosis. Their even body type suggests it, and it is documented in every study. In adult, it's also very interesting, because scoliosis in older people almost always occur as a result of another underlying condition. very often that underlying condition is osteoporosis. And then, as you said, vertebral fracture will further can lead to instability of the spine, loss of joint congruency, and what we call de novo scoliosis. De novo is an adult onset scoliosis, someone who didn't have scoliosis before. And osteoporosis, the change in the bone, one can form scoliosis, you can see here, and two, as you said, can enhance, progresses the scoliosis from menopause time and on, because of the decompression, the lack of bone, the decrease, it just changes the whole shape of this.
Right.
We are about to finish almost. We can see here also a 56-year-old with a just a little shifted spine. And in 4 years, her osteoporosis progressed, or maybe she was osteopenic here and become osteoporosis. And the degree of curvature, as you said, because of some vertebral compression and fracture and this, her scoliosis got worsened. And very interesting is there were studies done to check the hormonal effect on development of scoliosis. What does it mean? They wanted to see the mechanism of osteoporosis in adolescent idiopathic scoliosis. It's an experimental scoliosis on chickens and also on mice. What this group did is a magnificent group of surgeons here that I'm familiar with. Some of them is not a great research, but it's a research that give us a way to treat. They saw that melatonin is the sleeping hormone, but it also have other effects. Melatonin deficiency reduces osteoblast proliferation. What is osteoblast proliferation? Is the cells that creates bone in the body. Osteoblast is creating bone, and osteoclast is breaking bone. So melatonin, the hormone, the sleeping hormone that we need, that comes to us by being in the sun and getting some vitamin D through the eyes. That's why we need some time in the sun. Obviously not in 116 degrees at 2 o'clock in the afternoon, but in the morning and later in the afternoon, we need it. But lack of it, what did they do? They, unfortunately, the researchers penalized, they took away the part in the brain that release melatonin to the body. And when they cut this part in the brain, the pineal gland, these mice or this chicken develop scoliosis immediately.
That is fascinating.
Correct. And more fascinating is that after the creation of the scoliosis, when they couldn't bring the pineal gland back to the brain, but they administered via injection melatonin consistently to these animals, they regained their spine back straight.
Wow.
Right. But this is on animal, never done on humans, and we don't know exactly how to, but this is one of the factors. And so what does it say? That melatonin deficiency reduces the formation of bone and leads to the development of scoliosis and osteoporosis, because lack of bone formation and in this direction, I guess, was also incorporated osteoporosis and scoliosis correlation.
Right.
The restoration of melatonin prevented the development of scoliosis and osteoporosis. indicating that melatonin levels may be crucial to the development of deformity and osteoporosis in adolescent idiopathic scoliosis patients. So children need their sleep time.
Yeah.
Yeah, but it's not just that, because there are many people who don't sleep well and they don't develop scoliosis,
Right.
including me.
So a question about scoliosis, osteoporosis, and spinal fusions. I know this is coming. Yeah, well, I'll just ask the question. Would a spinal fusion prevent scoliosis progression? And perhaps we can say maybe there's some osteoporosis going on at the same time.
Yes, listen, spinal fusion, its goal, correcting the spine first, preventing progression, sure, if it's done while the spine is immature. And the osteoporosis, since it's also some genetic, some hereditary, some mineral, hormonal factors. I am not sure about the fusion preventing the osteoporosis, but the fusion prevent the consequences, the risk factors of fractures of the spine, because the spine is right now held by rods.
Right. And what about those adjacent segments above and
Okay,
below?
right. Still, also with that, there are still women that they were fused, but the segments below and above can fall into more kyphosis that needs to be taken care. I have a woman. Do you see this presentation too right now, what I'm showing, or not really?
Just the original.
Just the original.
Scoliosis.
So I will take this slide. 1 second, I'll take something to show you. If I put this here, hold on, it's coming. So I saw a patient that was operated for scoliosis in the lumbar spine. And here you can see that over 8 years, her thoracic became more kyphotic compared to 2010. So right above the fusion, there is a risk for increased kyphosis, especially if it's an osteoporosis. If she have osteoporosis too, she does. So if she's not going to strengthen and work on the above the fusion extension to neutral, or starting with extension, but to whatever she can accomplish properly for posture, then yes, it can be, the osteoporosis can continue.
Okay.
Have its effect. So to summarize all, and then I'll take some questions. Osteoporosis is a silent condition and can cause decreased health-related quality of life, like function and walking and balance and, God forbid, fall and all of that. It affects women more than men, but it affects also, and maybe I should add here, but also children, more related with scoliosis, because we know there is a correlation with low bone density with scoliosis. Have a relationship with hyperkyphosis and scoliosis. Postural awareness and extension biased exercises are highly important, and maybe avoidance of flexion. We didn't speak about rotation and side bending, so I will mention it here. When the osteoporosis is, when the fracture, if there is a fracture and it's not acute anymore, maybe after a few months, you can start to do rotation and side bending, but not flexion is not so recommended, almost forever. Medical intervention, like medication, through IV or through medicine, and and right nutrition or surgery if needed is important to prevent the osteoporosis cascade. And it's never too late to get strong and healthy. This woman on the left here is 85-year-old, Australian #1 champion of bodybuilder, started at age 65.
That's fantastic.
Honestly, yes, she's my role model. When I always say to myself, okay, I'm deconditioned, I can start at 60, she's in my mind. And this is it. If you have questions, I am okay to stay here with you. And this is my lovely Gali and our little dog, Shemesh, or Sunny. Yeah.
So cute. So we do have a question. I think that you've answered this, but I'm going to put it up because it brings up something that we didn't yet touch on. And this question is, what protective steps would you recommend for someone who has been prescribed aromatase inhibitor for breast cancer prevention? So I just want to bring this up because I think it's important for people to know that there are certain medications that do decrease bone density. I know American Bone Health, the website, has a list of such medications if people, it's something just really important to be aware of. And I do think that, you've kind of talked about the protective steps of, it's never too late to start strengthening and working on balance and all of the things that we've kind of been talking about.
And weight bearing, yeah.
Weight bearing, yeah.
But what exactly is the question? And maybe you can answer better. Maybe you have even a better...
Yeah, so I think the question is about a drug that's being taken for breast cancer prevention. And I'm guessing that this is one of the drugs that does decrease bone density. And so I think the question is about what other, knowing that is a drug that decreases bone density, what things can be done. And I think it's that list that you kind of talked about in the summary. It just is a little bit more amplified because this person is on a medication that decreases bone density.
Right. I guess to do the rest of these.
Mm-hmm.
Right. It's not my place to comment on medication and doctor decisions and what yes and what no. Maybe one day I'll be a doctor, but medical doctor. But no, I cannot comment on that. Speak to the doctor about. They probably know, but if not, speak to a metabolic bone disease doctor in addition to your oncologist.
Oh, that's a great suggestion. Can you say that again?
Yes. In addition to doing here physically the exercises and good nutrition, is to speak to how did I call it? I forgot. Metabolic bone disease doctors. They are great in New York City, I know, but anywhere you are. And tell them about what you take for the oncology. Yeah.
And just there was some clarification. So there's a thank you. And then also that the aromatase inhibitors, it's a drug that strips away the estrogen. So, yeah. Excellent. Okay. I think that's it for right now. Thank you so much for your time, Hagit. This has been wonderful.
My pleasure.
And it's always, always, always nice to speak with you.
And with you too.
Absorb all of the knowledge you have to offer.
Thank you, Jen.
Okay. Have a wonderful evening. I know it's late for you there. What time is it?
Oh, the night just began. It's 10:40.
Okay. Great. Just the beginning of the night. Okay. Thank you from all of us and have a good night.
You're welcome. Good night. Everyone be safe. Check yourself. and do the right exercise, consult with a good physical therapist, or refer to Jen and myself too.
Great. Thank you, Hagit. Bye.
You're welcome. Bye-bye.